السلام عليكم ورحمة الله وبركاته جميعا. أهلا وسهلا بكم اليوم في سهرتنا. أسميها سهرة إن شاء الله لأنه معانا دكتورة سناء جايل السلمي، شخص متخصص في جراحة القلب بمركز الملك فيصل للقلب بالحرس الوطني بجدة. حاصلة على شهادة البكالوريوس دكتور صيدلة من جامعة الملك عبد العزيز، وبكالوريوس دكتور صيدلة أيضا من جامعة سانت لويس الأمريكية، وريزيدنسي من مستشفيات هارفارد الأمريكية. حتكون معنا في سهرتنا بعنوان الاضطرابات التجلط المصاحبة للكوفيد 19. استمتعوا اليوم مع الدكتورة سناء، وأتمنى لكم يعني سهرة ودورة ولقاء ممتع. اتفضل يا دكتورة، المايك معك.
Islam. Thank you so much for the introduction, and good evening, everyone. Sorry we kept you late, and I'm so happy that you're joining us tonight, and I wish that you learned something new. So as you may all know that there is increasing communications worldwide reporting that hospitalized patients. Do you see my screen?
Yeah, sorry, I forgot that. Yeah, you can do it now.
Okay. Is it up? Do you see it now?
It's clear. Yeah, go ahead.
Perfect. Thank you. Okay. So as you may all know that there is increasing communications worldwide reporting that hospitalized critically ill COVID-19 patients are frequently developing laboratory abnormalities compatible with hypercoagulability and clinically at higher prevalence of thrombotic events. In addition to deep vein thrombosis and pulmonary embolism, thrombosis in the ECMO as well as the arterial thrombosis have been reported in those patients. So tonight we will be discussing all of this in addition to my objectives for tonight. I don't think it's working.
All right. Yeah, it's working.
Yeah, thank you. Yeah, thank you. Sorry about that. So my objectives are for tonight are to describe the pathophysiology of COVID-19 and its related cardiovascular manifestations, to define the COVID-associated coagulopathy and discuss the challenges that we may face in terms of diagnosing and managing patients with COVID-associated coagulopathy. And finally, I'll be reviewing the published evidence for the proposed management for COVID-associated coagulopathy. So before I start, I have nothing to disclose. And to start off, coronavirus disease 2019 or COVID-19 is a global pandemic impacting nearly 12.8 million patients worldwide as of July 13th. It was first reported in Wuhan, China in December of the last year, and since then it's been spreading very rapidly due to its robust capacity for human-to-human transmission, long incubation period, as well as having asymptomatic infection characteristics. COVID-19 is caused by the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2, which invades human cells through binding of the viral surface spike protein to the human angiotensin converting enzyme 2 receptors, which is a homolog of ACE that converts angiotensin 2 to angiotensin 1 through 7 and cleaves angiotensin 1 to angiotensin 1 through 9. ACE2 is expressed in the lung, principally type 2 alveolar cells, and appears to be the predominant portal of entry. ACE2 is highly expressed in the heart as well, and in addition to the heart and lung, ACE2 is expressed in the intestinal epithelium, vascular endothelium, as well as the kidneys, providing a mechanism for the multi-organ dysfunction that can be seen with SARS-CoV-2 infection. So after the endocytosis takes place, the ACE2 is further downregulated, and this results in an opposed angiotensin 2 accumulation and local activation of the renin-angiotensin aldosterone system that may mediate lung injury responses to viral insults. Cardiovascular disease was a common comorbidity in patients with COVID-19 precursors, SARS and MERS. And actually, this increased presence of cardiovascular comorbidities holds true for COVID-19 as well, most notably among those with more severe disease. And as we can see here in this slide, in a early cohort analyses, that majority of patients with COVID-19 present with hypertension as a comorbidity, followed by diabetes and other cardiovascular diseases. And it's important to note that not only the prevalence of cardiovascular diseases in COVID-19 is high, but also the case fatality rate has differed significantly around the world. And compared to patients with no comorbidities in whom the C of R is 0.9%, those with medical comorbidities have a significantly increased TFR, like 10.5% in patients with cardiovascular diseases, followed by 7.3% in diabetic patients and 6% in those with hypertension. So the exact mechanism of these associations remain unclear at this time. However, potential explanations include cardiovascular disease being more prevalent in those with advancing age, a functionality impaired immune system, elevated levels of ACE2, or a predisposition to COVID-19 for those with cardiovascular diseases. So moving to the cardiovascular manifestations related directly to COVID-19, you can see patients with myocarditis, myocardial injury, acute coronary syndrome, cardiomyopathy, congestive heart failure, cardiogenic shock, fatal arrhythmias, as well as thromboembolic disease. And for the purpose of this talk tonight, inshallah, we will be focusing more on the thromboembolic disease in COVID-19 patients, or how they call it, COVID-associated coagulopathy. So early data showed that patients with severe COVID-19 infection can develop a coagulopathy meeting criteria for disseminated intravascular coagulopathy per the ISTH criteria included here, with fulminant activation of coagulation resulting in widespread microvascular thrombosis as well as consumption of coagulation factors. And this could be reflected by seeing patients with thrombocytopenia, prolongation of the prothrombin time, INR, PTT, elevation of D-dimer levels, as well as having decreased fibrinogen levels. We can see here in this slide a table of a couple of cohort analyses that looked at these coagulation abnormalities as well as the outcomes. And it was found that both mild thrombocytopenia and increased D-dimer levels were associated with a higher risk of requiring mechanical ventilation, intensive care unit admission, or death. Additionally, it was found that disease severity is variably associated with prolongation of the prothrombin time, INR, as well as thrombin time, and variably by a trend toward shortened activated partial thromboplastin time, or APTT. So why this is happening, why all of these coagulation abnormalities have been seen in patients with COVID-19. So in critically ill COVID-19 patients, there appear to be at least two separate pathologic coagulation processes that are important in producing clinical manifestations. So the first process is that in the microcirculation of the lung, as well as potentially other organs, there is a local direct vascular and endothelial injury producing microvascular clot formation, as well as angiopathy. Not only this, but also in the systemic circulation and due to the hypercoagulability with hyperfibrinogenemia, as well as enhanced platelet vessel wall interaction, there is a potential for large vessel thrombosis and major thromboembolic complications, including PE, that is reported in around 20 to 30% of ICU patients. And additionally, the prevalence of arterial thrombosis in COVID-19 patients was found to be high, and the involvement of the antiphospholipid antibodies has been suggested to be could be an underlying mechanism. So how prevalent is this thrombosis in COVID-19 patients? In an early study by Tang et al. From Wuhan, it was found that 71% of non-survivors from COVID-19 patients met the ISTH criteria for GIC, compared to 0.4% of survivors. Not only this, but it was also found that any elevated D-dimer at admission, as well as markedly increasing D-dimer levels, and we're talking here about 3 to 4-fold increase in the D-dimer levels. So both were associated with high mortality. And this could likely reflect the coagulation activation from the infection itself, sepsis, cytokine storm, or impending organ failure. And additionally, data showed that majority of hospitalized COVID-19 patients do actually share similar strong clinical intrinsic and extrinsic risk factors for VTE, which include advanced age, obesity, immobility, stroke with paralysis, a history of cancer or active cancer, management in an intensive care unit or coronary care unit setting, as well as having prior history of VTE or non-thrombophilia. So the more the patient have these risk factors, the more it's challenging for the clinicians to diagnose those patients. Typically, or especially for critically ill patients in home, it's important to reliably confirm or exclude VTE. So when we talk about imaging studies for DVT or deep vein thrombosis, as well as pulmonary embolism, it should be avoided due to concerns of transmitting infection in non-COVID-19 hospital wards or to healthcare workers themselves. And the frequent finding of an elevated D-dimer levels in very ill hospitalized COVID-19 patients may actually prompt an aggressive diagnostic approach for VTE, despite the controversy that a very elevated D-dimer levels greater than 4 milligrams per liter may not be a reliable predictor of VTE in this population, but rather a marker of poor overall outcome. And lastly, bedside imaging studies such as point-of-care compression ultrasonography to assess for lower and upper extremity DVT, or the bedside echocardiography to assess for right ventricular strain associated with PE may be difficult. May be difficult to obtain due to potential instability or the requirement of prone positioning in patients with acute respiratory distress syndrome. The other reason is that they both may lack sufficient specificity and sensitivity to diagnose VTE, as we know that patients with pneumonia may have right ventricular strain without having PE. So they're all legit concerns. However, these all concerns should be balanced by the emerging data that incidence of VTE in hospitalized COVID-19 patients with severe pneumonia or those in ICU settings is actually higher than that reported by historical data in similar patients. Hence, it is recommended that all practitioners should use standard of care objective testing to diagnose VTE based on clinical index of suspicion. And it's actually recommended against the routine screening for VTE using bedside Doppler ultrasonography of the lower extremities or based on elevated D-dimer levels. So moving to the more fun part of this talk tonight, which is about the management of COVID-associated coagulopathy. And when we talk about management of COVID-associated coagulopathy, we need to talk about what coagulation parameters that we need to obtain in patients and when, as well as the proper VTE thromboprophylaxis, given the high incidence of VTE in such patients population. We'll also need to talk about the role of treatment or prevention of microvascular thrombosis, as well as the place of therapy of antiplatelet therapies in COVID-19 patients. And finally, we will be discussing the clinical indications when to start therapeutic anticoagulations in such patients. So to start off with the coagulation test surveillance, it is recommended by the ISTH that all hospitalized patients with a newly confirmed or suspected COVID infection, that all should have coagulation testing performed on admission, including D-dimer levels, PT, APTT, fibrinogen, and platelet count. And then these parameters could be repeated every 24 hours to 72 hours or as clinically indicated. However, if the patient is in the ICU, it is recommended that you trend these parameters daily. So now you have a patient, you obtained all of these parameters on them. What do you do next? So VTE thromboprophylaxis. So there was an early retrospective cohort analysis that was published earlier this year to validate the efficacy of heparin in patients with COVID-19. They looked at around 450 patients with severe COVID. And severe COVID was defined as having one of the following: with a respiratory rate greater than or 30 plus per minute, arterial oxygen saturation of less than or 93% at rest, and the PaO2 to FiO2 ratio of less than or 300 millimercury. So they did exclude those patients with bleeding diathesis, hospital stay of less than 7 days, lack of any information regarding coagulation parameters and medications, and those with age of less than 18 years old. Of the 450 patients, 99 of them did receive heparin for 7 days or longer, with the majority of them being received enoxaparin. For their outcomes, they looked at 28-day mortality stratified by D-dimer levels, as well as the sepsis-induced coagulopathy score, which is calculated by looking at the platelet count, PT-INR, SOFA score, and it is reported that if the patient is having a score of 4 or greater, this is associated with bad outcomes. So moving to the results of this retrospective cohort, before we discuss results, let me orient you to this bar chart. So the y-axis here represent the parameters, the stratified parameters, and the x-axis represents the 28-day mortality. The red bars represent patients with heparin non-users, and the blue ones represent the patients with heparin users. So it was found that patients with sepsis-induced score of 4 or greater, and those with D-dimer levels of 6 and 8 upper limit of normal, both associated with significantly reduced 28-day mortality rate. And based on these findings, the ISTH did publish a simple and easy followable algorithm for the management of COVID-19 coagulopathy. So they have this algorithm in which they recommend that all confirmed or suspected COVID patients, they have to get their D-dimer level checked, prothrombin time, as well as platelet count and fibrinogen upon admission, as mentioned earlier. And all of these markers are listed, given in the decreasing orders of importance, as we can see here. So let's say that all parameters were normal and the decision was made to discharge the patient. Then you can use these values as a baseline value for if the patient represented with any symptoms. However, if the decision was made to admit the patient for any other clinical reasons, then it's recommended to monitor these parameters daily and then to start the patients on standard dose prophylactic low molecular weight heparin. If you checked all of these parameters, and it was found that the D-dimer level was markedly increased by 3 to 4-fold, and the prothrombin time was prolonged, and the platelet count was 100, or fibrinogen level of less than 2 grams per liter. Would you do that? It's recommended to admit the patient even if they don't have any other concerns, and to monitor these parameters once or twice daily. And again, to start them on prophylactic dose low molecular weight heparin. They also included in the statement a protocol for when to transfuse blood to those patients, as well as when to consider any experimental therapies. So the baseline that it's recommended to start prophylactic dose low molecular weight heparin in all confirmed or suspected COVID hospitalized patients. Not only the ISTH went with that recommendation, but also the American Society of Hematology. in which also they recommended against the use of full anticoagulation and unless there is documented VTE. CHEST guidelines also recommended to thromboprophylactic all critically ill patients with COVID-19. However, they stated that it is suggested and they did not really recommend, but they suggested that you can use thromboprophylaxis in hospitalized patients with COVID. The Italian Society on Thrombosis and Hemostasis went with the same recommendations as well. Additionally, the National Institute of Health. So now we have all of these statements and expert opinions. So what do you think the outcomes were? Unfortunately, there were a couple of papers published in Europe reporting that there is an incidence of increased VTE in ICU patients with COVID-19, despite being on systemic thromboprophylaxis. And one of these papers was the data from Netherlands, in which they looked at cumulative incidence of venous and arterial thrombotic events in around 184 patients in 3 different ICUs. And it was found that the cumulative incidence of venous and arterial thrombotic complications in ICU patients, despite being on systemic thromboprophylaxis, it was 31%, which is a very high number. With pulmonary embolism being the frequent thrombotic complication, followed by other venous thromboembolic as well as arterial thrombotic events as seen in that slide. And in case you were wondering what thromboprophylaxis they were using or what dose, they went with the natroprene. I know that we don't have it here. It's not even approved in the USA. It's only approved in Europe. It's also worth mentioning that 2 of the 3 ICUs initially used lower than the standard doses of low molecular weight heparin, and then they adjusted or they increased the doses over time. So what do you do now? Do we keep on giving the patients the same standard thromboprophylaxis doses, or do we need to give them a full anticoagulation doses? So luckily, there were a couple of papers published after the papers from Europe that showing that there increased incidence of VTE in those patients. So all of these societies recommended to go with something called intermediate intensity dose, or a stepped up dose. So they recommended whether doubling the standard prophylactic dose, instead of giving 40 milligram of enoxaparin, for example, once daily, you just give 40 milligram twice daily. Other institutions also went with half the therapeutic dose. Like for example, if you're giving enoxaparin, instead of giving 1 milligram per kilogram twice daily, they were giving 0.5 milligram per kilogram twice daily. So all of these societies recommended to go with this intermediate intensity dose in only high-risk patients. And every paper or every society defined their high-risk patients differently, which is very challenging for us as clinicians. Some of them did use the cutoff of the SIC score of 4 or greater, in addition to the VTE risk factors. And others just used the traditional VTE risk factors. You can see here the last guidelines, or the CHEST guidelines actually recommended against the use of intermediate intensity thromboprophylaxis, despite the increased incidence of VTE, despite patients being on systemic thromboprophylaxis. And they justified that because of the lack of RCTs at this time. So what about dosing per D-dimer? Is there any guidance? Is there any recommendation? Is it recommended? So I know that there is some institutions, they have their own protocols in which they adjust or increase the anticoagulation doses based on the D-dimer levels, which in my personal opinion, I think it's way aggressive and it can be risky. And as we all know that D-dimer elevation and other biomarkers have been associated with worse outcomes in patients with COVID-19. However, it's recommended against using the elevated D-dimer as the sole reason to trigger escalation anticoagulation dosing. So please do not do it. So if you were paying attention to all the statement that I mentioned earlier on what medications it's recommended, The preferred thromboprophylaxis is low molecular weight heparin or unfractionated heparin. But why is this? We all know that the large trials of the direct oral anticoagulants have shown that they're efficacious and they're safe to use for VTE prevention as well as treatment. So why we're using low molecular weight heparin or unfractionated heparin instead of using DOACs or warfarin? This is for many reasons. The vitamin K antagonist or warfarin, as well and the direct oral anticoagulants, have the drawback of having longer half-lives. We know that those patients are critically ill patients, and they may deteriorate at any time, and then you need to take them for a procedure, and it's challenging to reverse. They also have a lot of drug-drug interactions, especially with experimenting different medications in COVID-19 patients. For DOAC specifically, there could be lack of timely availability of effective reversal agent at some centers. And lastly, we know that COVID patients could be presented with some sort of renal and hepatic impairment, which makes it challenging to use any of these agents. On the other hand, we know that low molecular weight heparin and fractionated heparin both do have shorter half-lives. They have also an added anti-inflammatory properties which could be beneficial in such patient population. They have less drug-drug interactions, and it's easy to reverse these medications. So which one do you go with? Do you go with low molecular weight heparin or unfractionated heparin? Is there any recommendation on what agent would you choose first? So again, we're going to just review the cons and pros of each of these medications. So if using unfractionated heparin for therapeutic doses, it takes time to achieve the therapeutic PTT. Not only that, but we know that those patients could present with prolonged PTT at baseline, which makes it very challenging to rely on the PTT to adjust their heparin doses or rate. And you may came across a couple of institutions that recommend to go with monitoring anti-TIN A instead of PTT with unfractionated heparin in COVID-19 patients. There's also this increased healthcare exposure for frequent blood draws with therapeutic doses, as well as with more frequent administration. The other drawback of using unfractionated heparin in COVID-19 patient is that those patients also could present with increased fibrinogen levels, which may increases the heparin resistance. And lastly, we know that heparin can induce thrombocytopenia, and they already can have thrombocytopenia at baseline. As opposed to low molecular weight heparin, in which it has this predictable dose-response relationship that we love about low molecular weight heparin, it also lacks the need for routine monitoring, and it's less frequent than unfractionated heparin. So what about thrombolytics? Is it recommended in COVID-19 patients? Is there any guidance on their use, or is there any recommendation against their use? So there was a paper or a case series of 3 cases with COVID-19 suffering from acute respiratory distress syndrome with a respiratory failure, in which the decision was made to administer those patients a total of 50 milligram alteplase. And in all 3 cases, the patients demonstrated an initial improvement in their PF ratio, with improvements ranging from 38% to 100% improvement. But unfortunately, these observed improvements were transient and lost over time in all 3 patients after completion of their TPA infusions. And the authors here argued that the TPA dose they used could be a very low dose, that they couldn't see that the outcomes didn't last longer. And they argued that if they used the dose for PE, they might have gotten better outcomes with TPA in those patients. However, we all know that systemic administration of thrombolytics for PE has been associated with major bleeding and intracranial hemorrhage rates of almost 10% and 1 to 2% respectively. Not only this, but thrombolytic therapy is not actually recommended for the vast majority of patients with PE, given limited efficacy data in patients who are hemodynamically stable. And as of now, there is no high quality evidence for giving alteplase or any other thrombolytic therapy for treatment of COVID-associated coagulopathy, because the risk outweighs the benefits. So now we know what dose should we go with, what agent should we go with, but the challenge here is that, do we need to discharge those patients on thromboprophylaxis or not? So it's very known that the risk of hospital-associated VTE extends for up to 6 weeks post-hospital discharge in high VTE risk medically ill patients, including those with pneumonia, sepsis, and any condition requiring management in ICU setting. Not only that, but also at least 60% of all VTE events in medically ill patients occur in the post-hospital discharge period, with the first 3 weeks being associated with a greater than 5-fold increased risk in fatal PE. We also know that earlier studies of extended thromboprophylaxis with DOACs did actually reveal either limited efficacy or an increase in major bleed risk. And particularly due to these safety concerns, the most recent antithrombotic guidelines recommended against routine post-discharge thromboprophylaxis in medically ill patients, including those with pneumonia. And however, more recent data reveals that in selected population at high VTE risk and low bleed risk, based on key risk factors or risk models for thrombosis and bleeding, the extended duration thromboprophylaxis for approximately 4 weeks with prophylactic dose low molecular weight heparin or rivaroxaban or petrexaban provides a net clinical benefit by reducing VTE risk without incurring a significant increase in the risk of major bleeding. And in the absence of COVID-19 specific data, majority of the society considered it's reasonable to extend thromboprophylaxis in high-risk patients for at least 7 days and up to 45 days. The only society that recommended against the extended thromboprophylaxis were CHEST as well as the NIH. So given all these consensus papers and expert opinions, what do we do here at our institutions at the National Guard here in Jeddah? So we actually came up with this very simple algorithm to follow, and we assess every hospitalized patients with confirmed or suspected COVID-19 patients and see if they're on chronic anticoagulation. If yes, what agent they are on. If they were on warfarin or DOACs, then we recommend to switch to either low molecular weight heparin or unfractionated heparin. However, if the patient is having any valvular atrial fibrillation, having any mechanical valves, antiphospholipid antibody syndrome, those with left ventricular assisted device, or pregnant ladies, we recommend to continue with warfarin therapy in those patients. If the patient was on low molecular weight heparin, then we just recommend to continue the same therapeutic doses and based on their renal function. If the patient is not on chronic anticoagulation and there is no contraindication, meaning that no active bleeding or platelets less than 50 for therapeutic anticoagulation or less than 30 for prophylactic dosing, then if the patient is in the regular floor or guest house, we do recommend to start standard dose thromboprophylaxis, again, by looking at their renal function as well as their weight. And then when the patient is discharged, we recommend to continue thromboprophylaxis for 14 to 13 days in those with high-risk VTE patients. If the patient is not on anticoagulation and no contraindication, but they were in critical care setting like ICU or CCU, we see if the patient is having any new documented or suspected VTE. If yes, then we'll just start therapeutic doses as shown in table 1. If the patient is not showing any sign or symptom of documented or suspected VTE, then we recommend to start intermediate intensity dose thromboprophylaxis. And here we chose to doubling the standard doses instead of using half the therapeutic doses. And again, it's based on the renal function as well as the patient's weight. And then we recommend that when the patient transferred to the floor, then to continue the intermediate dose for 4 to 7 days or as clinically indicated, and then to switch them back to the standard dose. So we all know this is not based on RCTs by any mean. This is all based on the consensus papers that have been published or expert opinions or how like the large institutions have been doing or treating those patients. However, the good news is that there are a couple of ongoing RCTs looking at the different dosing strategies of heparin in those patients, in COVID-19 patients. So hopefully they come out early and guide us for proper managing those patients. So we talked about VTE thromboprophylaxis. What about microvascular thrombosis? I mentioned earlier that those patients at high risk for developing microvascular thrombosis and having SIC. So the basis of SIC management strategy is the rapid and timely treatment of the underlying infection. However, we all know that no specific antiviral therapy for SARS-CoV-2 is available to date. And for the physiologic anticoagulants, including activated protein C, thrombomodulin, and antithrombin, they all previously studied in randomized clinical trials. However, they all demonstrated limited efficacy, but all patients with sepsis were included, not just those with sepsis-associated coagulopathy and DIC. And there is a post-hoc database analysis examining septic patients with laboratory-proven DIC reported that there is a decreased mortality examining antithrombin and thrombomodulin supplementation, and there was a trend toward improved survival in septic patients. However, antithrombin levels have not been found to be decreased significantly in COVID-19 infection patients, and as of this time, there is no recommendation regarding the use of any of these three agents to treat microvascular thrombosis. And in regards to the prevention of microvascular thrombosis, it's true that the concept of using full-dose anticoagulation in COVID-19 patients for preventing microvascular thrombosis during severe infection has been considered. However, there are no data to support full-dose anticoagulation at this time for this indication. So what about antiplatelet therapies? Is there any role? So although platelets may be involved in the local and systemic thrombotic response in COVID-19 coagulopathy, adding a platelet inhibitor to unfractionated heparin or low molecular weight heparin at therapeutic doses would increase the potential for risk for bleeding. And we all know this phenomenon in acute coronary syndromes, where anticoagulant therapy along with antiplatelet therapy may decrease arterial thrombosis, true, but it is associated with increased bleeding risk that also increases adverse events, and most PTY12 inhibitors also have long half-lives without the availability of any reversal agent. And it's important to know that the microvascular thrombosis, DVT, and pulmonary artery thrombosis with COVID-19 all appear to be due to abnormally elevated coagulation factor levels and the absence of the usual protective effects of the vascular endothelium itself. Hence, the role of platelet activation in this process is less well defined and not clearly implicated or recommended at this time. Moving to the last part of my presentation for tonight, which is when to consider therapeutic anticoagulation in patients with COVID-19. So for COVID-19 patients with other indications for anticoagulation, such as having new or recent diagnosis of VTE, atrial fibrillation, mechanical cardiac valves, or those with long-term secondary VTE prevention, anticoagulation should be continued at full dose or a dose equivalent to their equivalent dose or current dose. And the question regarding using therapeutic anticoagulation for those with presumed PE has actually been encountered in many ICUs around the world due to the difficulty moving mechanically ventilated patients to computed tomography scanners and the desire to limit staff exposure to COVID-19 patients, as mentioned earlier. However, it is reasonable to consider full therapeutic anticoagulation in those patients if they show any signs and symptoms of clinical findings of sudden respiratory decompensation, if they showed any evidence of right heart strain on echo, or if they have any DVT seen on lower extremity ultrasound. And again, as mentioned earlier, if the patient was on vitamin K antagonist or direct oral anticoagulants, then it's recommended to switch them to low molecular weight heparin, and if it's contraindicated, then to unfractionated heparin. Again, those patients with the indications that I mentioned earlier, they should be continued on warfarin therapy. So in summary, there is increased case fatality rate in patients with COVID-19 and cardiovascular comorbidities. And there's also this increased incidence of VTE in ICU patients with COVID-19, despite being on systemic thromboprophylaxis. Hence, there is a need for increasing the thromboprophylaxis doses in COVID-19 patients. However, we still lack randomized control trials. We need further data to proper managing those patients. With this, I end my presentation for tonight, and I'll be happy to take any comment or feedback or questions. Thank you.
Thank you very much for this lecture. Yeah, you have any questions, please go direct to the box of Q&A, question and answer. You can type your question there, please. Any questions? This is a day you're waiting for. The previous days, all the question about the coagulopathy and coagulation and COVID-19. This is your days. Please ask. We have an expert today. Oh my God. No one. They're afraid of you.
Thank you so much for the valuable lecture. Oh, thank you so much.
They're afraid of you. I don't know what's wrong today.
Why? Great question. Why we can't rely on D-dimer? I mentioned that D-dimer could be a biomarker for worsening outcomes in those patients, but it's not recommended to use it as a sole biomarker to escalate anticoagulation doses, because like it's already at baseline elevated, so it's not reliable.
All right.
And I think I'm not sure, but I think some hospitals here go with an HS protocol in which they increase the doses of the anticoagulation based on the D-dimer levels, but that's not recommended.
We have another one.
There's no need to add. No, it's okay.
Cool.
Can we mention those who are supposed to start?
Arrived.
Can we mention those who is supposed to start anticoagulation therapy directly? I don't think I get the question. Do you mean full therapeutic doses? I'm not sure I understand that question.
Okay, Abdulwahab, you can ask again, please. Repeat your question. Yeah. What?
السلام عليكم. حاليا أبغى أعرف المفروض حاليا نعطي إنوكسابارين جرعة وقائية أو علاجية. Okay, so in summary, if the patient is admitted to regular floor, you just go with standard doses inoxaparin اللي هي الجرعة الوقائية. Unless there is signs and symptoms of deteriorating or VTE. If the patient is admitted to the ICU, then it's not recommended. It's reasonable to go with an intermediate intensity dose, not therapeutic dose, مو علاجية. Intermediate dose, whether by giving, by doubling the prophylactic dose. I said, for example, if the dose is 40 milligram once daily for that patient based on renal function, then you just give 40 milligram twice daily. Or you can use the 0.5 milligram per kilogram twice daily instead, if that is easier for you. This is not recommendation. This is all expert opinions. We usually monitor HEPA. Sorry, the question is gone.
Okay, we can take the first one from Asma.
Okay. Does the clinical manifestations of the disease justify starting the low molecular weight heparin as VTE prophylaxis before receiving the D-dimer result? Yes. Despite the D-dimer level of the D-dimer value, all COVID patients, suspected or confirmed COVID patients, should be placed on low molecular weight heparin as a prophylactic. Right. Does that answer the question? Oh, thank you. Is there any specific risk factor associated with COVID-associated coagulopathy? I guess it's the same VTE risk factors that I already went over. Yes, all the coagulation parameters should be obtained on all suspected or confirmed COVID patients. It depends. Ahmed Majrash, are you asking about those in regular floor or ICU patients? APTT versus Antitin A preferred in COVID-19 for heparin monitoring. Hi, Maha. Maha is my resident. Okay. So as mentioned earlier, a couple institutions go with monitoring Antitin A levels, giving the prolonged PT at baseline. However, it's like none of the huge big society recommended to go with Antitin A level versus PTT. That's why it's preferred to go with low molecular weight heparin unless the patient is, the renal is impaired, very impaired. Oh, wow. So Sultan Baraki, my question is related to prolonged thromboprophylaxis. We have bad experience with some patients developed extensive MI or VTE shortly after discharge. What do you recommend?
It's a beautiful question.
I know, but that's so scary.
Yeah.
Yeah. Sultan, do you guys usually discharge those patients on thromboprophylaxis? I know some clinicians are against, some clinicians are with. I believe in the ISTH paper, 50% of the clinicians went with giving, extending the thromboprophylaxis. I don't know how to feel about it, but I feel, I believe that we can, if the patient is at a very high risk of developing VTE, then we can extend thromboprophylaxis in those patients. But I'll go with this. I'll go with the standard dose. Is in a situation if the patient is still treating, is it recommended to increase the dose, or is just expert opinion and you can go with it? So we adopted all the expert opinions and the consensus papers and came up with a chart I showed you. So we recommend at our institution now, we recommend to up the dose or escalate the dose if the patient is showing any sign and symptoms of deterioration. Yes. D-dimer test. People love D-dimer.
Yeah, it's not available. It's not available. You know, it's rare to find D-dimer in some hospital right now.
Oh, okay. Do not do. Okay. Yeah, it's
demand is very high to D-dimer right now.
Right. Yeah. So it's recommended to test D-dimer level upon admission, and then you can trend, but do not escalate or de-escalate the dose of anticoagulation based on that. Cannot use totally right or wrong. You mean totally do not use it for dosing, dose adjustment, or do not use it for for trending. Which is better to use in Asians, sweatshirt, half-life, or like half-life? Guys, I went over all of these in my presentation. Which is better to use anticoagulant agents with shorter half-life? You tell me, or long half-life. Of course, we want to go with short half-lives because those patients are critically ill patients and they might be needing to undergo like a procedure or something. So we don't want to be in that position in which we cannot take them because they're anticoagulated.
All right, we go to the Ahmed Majroshi again.
Did you recommend heparin as prophylaxis in COVID positive renal patient as twice daily or 3 times? Based on their weight. Can I go back and show them the table?
Yeah, sure.
Okay.
You can share your screen again.
Okay, just screen. Oh.
With your kids.
Okay. So this is the intermediate intensity dose that we use in our institution based on the renal function and the BMI. So when you ask me, I don't know where is your patient fit. So maybe screenshot this would help. And the other 2 tables, they're like the standard dosing for standard thrombolytic dose and therapeutic dose. I hope this helps.
All right.
What is the duration of VTE treatment and the prophylaxis as well for COVID-19 patients? Is it the same with general population? No, we know that VTE treatment is a different scenario. You want to know if it's provoked or unprovoked. And the prophylaxis as well for COVID-19. So the prophylaxis, as long as the patient is hospitalized, you want to give them prophylactic dose. And then we talked about the extended thromboprophylaxis. If the patient is having high VTE risk, then you may consider discharging those patients on a standard prophylactic dose for up to 45 days. That's all like the expert opinions. Again, not RCTs. If I have a patient hemodialysis with dimer is more than 1, I'm afraid I didn't understand the question. If I have a patient, like a patient on hemodialysis, his D-dimer is more than 1, we can start enoxaparin. It's preferred to use unfractionated heparin in those patients. In patients with hemodialysis, we go with unfractionated heparin.
All right.
D-dimer test cannot use totally, right or wrong for both doses and trending. For doses, no, do not use it. Trending, you can trend it just to get an idea on how your patient is clinically doing. Thanks a lot, Dr. Your explanation much loaded. Thank you so much. Thank you so much.
All right. I think it's closing time right now.
Yeah, sure.
All right. Thank you very much. Can I stop your screen now?
Oh yeah, of course. I'm sorry.
No worries. Fine. I'm going to my screen now.
Yeah,
All right.
chats.
All right. I will go with Arabic because it's better for me.
Yeah, totally.
The people here, they asking the next one should be in Arabic because a lot of people with us, they need to be in the language in Arabic. I don't know what's wrong, but I think it's not that complicated because the term we talking about is common term. It's not difficult to understand, right?
It should be.
Yeah, no worries. Okay, thank you very much. Thank you, Dr. Sana, for today, for being here. This is a certificate from our administration. Thank you very much for your time. I know working after working, you need rest. You didn't take a rest today. You're with us today. Thank you very much for your time, for your effort, for your presentation. Thank you very much. Tomorrow we have another session with Dr. Samira Shahrani. You're gonna talk about the Novamix 30 differentiation between the different types of Paramix insulin. Tomorrow, 7:30 to 9:30 p.m. Don't miss this course. We target in this course the all physician, family medicine, and endocrinologist, and intern medicine, and ER physician, and PhD doctors and medical students too. Don't miss this tomorrow. About the certificate, should be attendance should be more than 85%. We're gonna account from the list. The platform of Zoom give us a name and the user, email user, and also they give us the duration. Should be the duration more than 85% to release the certificate. We gonna see everyone, the attendance time and the duration. If you have any question or inquiries, please just capture this one and send us your question or your anything you want to just type in and send it to us. About our colleagues from Irada, just go to the tickets, send the tickets. If you have any problem, any issue, just type in and I'm gonna answer your question and your inquiries. All our courses and lectures is recorded in our platform Irada, also on YouTube. You can visit and see it again and again and again. Thank you very much. This is our Twitter account. If you have anything on all courses, you can find the links, the posters. You can contact with us. Just go in our Twitter and just ask whatever you want. Thank you very much, Dr. Sana, to
Thank
be
you
here.
so much for having me.
No, thank you very much. We have to thank you for your time. We know you're tired. You just came out from your duty and just stick
I
out.
hope I made sense. I'm tired too, but I hope I made sense throughout the presentation.
All right. Thank you very much. Thank
Have
you.
a good night. Thank you.
Thank
Bye.
you. Bye bye. Bye bye. Thank you.